Hello. Today we're going to talk about care of the newborn, and we are going to do this in two parts. So we will start first with the assessment and what are the basic physiologic aspects of a newborn that we have to pay attention to. So when we say newborn examination, this is a systematic examination. So when we say systematic, there is a chronological step, and it involves physical assessment and neurological assessment. So when you say neurological, we're really paying attention to the brain, not just the shape, not just the contours, but signs of its functioning. So the objective of newborn examination is that we will be able to assess the infant's state of development of well-being. And the most important one is that we are able to detect right away if there is any deviation from normal. And from that baseline, we will have a good starting point to see how our newborn will progress as life continues. So, in terms of weeks when the newborn is born, we will call that newborn full term if it has reached 37 to 42 weeks, which is approximately about 259 to 294 days. Full term means it has reached the amount of time to be inside the womb and is really ready to be outside the world. Preterm will be any age before the 37 weeks, but it has to be past 28 weeks. So we call that birth as a preterm newborn. Okay. Prior to that 28 weeks, very low chance of survival. And post-term, that is 42 weeks. After 42 weeks, it means the infant is already, or the newborn is overdue. So upon birth, these are the general observations we have to right away assess using our clinical eye. We see the length of the infant. We see the head circumference, and that will be measured. We look at the way the infant move, the strength of the movement. So that would be our general observation. And of course, we look at the skin. Is it pale? Is it yellow? And then we do the head to toe assessment. So when we start with the head, we look at the face. Now, in the head, very distinct for a newborn is the presence of the fontanelle. Okay, we look at the face if there are any dysmorphic features. We go down, we look at the, we go specific, we look at the eyes. Is it blinking? We look at the mouth. Is it intact? Are there any cleft in there? We look at the chest as we go down. We look at how it rise and fall. We listen to heart sounds. We listen for extra sound. We look at the effort when the infant breathes, if there is a notable chest retraction. We look at the infant or the newborn fingers. Is it complete? Okay. Are there any extra digits in there? Does the palms have creases or lines? Because those are indicative of something not normal. We look at the newborn's abdomen. Is it distended? Because that could be a sign of some inflammatory reactions. The inguinal, we feel for the pulses in the femoral area. We look at the hips. Are they aligned? Are they symmetrical? Are the bones anchoring well? We look at the limbs. We look at the fingers, the toes, and see if there's 5 of them in both sides, or are there extra ones or missing ones. We look at the anus. Is it open or patent? If it's a male, we look at the testicles. Is it in there? is it in there, or it's we have these undescended testicles. We look at the genitalia. Is it male or female? Okay, so basic use of our clinical eye, we can already see if generally our newborn is as we expect what a newborn should have. Okay. So this critical examination, we actually do this 3 times. The very first will be one in labor room within 2 hours after birth. Right away, we do that clinical eye assessment and those basic respiratory, heart rate assessment. The second thorough examination will be before the discharge of the newborn. And the third one will be when the newborn returns for a follow-up checkup, which is after 6 to 8 weeks, or about a month and a half to 2 months of neonatal life. So in this slide, you will actually see a very detailed guide on what to examine in a newborn from head to toe. Earlier, we did a general observation. We look at the newborn from head to toe. Then when we look at the newborn closer, we start with the head. We look at the neck. Then in that head and neck, we look at head circumference. Are there any swelling in the scalp you have here? Is it a caput, a succedanum, or a cephal hematoma? We will talk about that later. We look at the fontanelle, suture, so be familiar with this term now, the eyes, the nose, the mouth, all the facial features. And then we go down to the chest and the abdomen. Here we look at the shape. Is it hyper inflated? The belly. We look at the nipple, the abdomen, the umbilicus. We listen for breathing sounds, the respiratory effort. We listen for heart sound. We go down to the hip, the genital, the anus. We feel for the pulses in the femur. We look at hip stability. Take note of this word, ortolani and Barlius maneuver. These are signs that there are hip dislocations. We look at the testicles for the male. If there's fluid inside the testicles, is the anus patent? Is it connected to the GI system? Then we look at the limbs, the spines. So look at the arms, the fingers, the toes. We look at the length of the back. Is it curvature? Is it deformed? And then we look at the neuro aspect, and that's the different reflexes, which is now an assessment on is the brain working as expected. And that will be part of our lecture part 2. So here is another detailed key to take note when assessing your newborn. Okay, weight would be very important, baseline weight, because we would like to see if our infant newborn is progressing. We look at the skin. Is the newborn breathing well? Is the oxygen circulating well? Are there extra marks or colors in the newborn that signal something like birthmarks, cyanosis, rashes? So you can go again one by one in each of these key features that needs to be assessed. We have terms here. If you go down to the hips, I mentioned earlier Barlow and Ortolani. These are very important features to be noted if there are hip dislocations. which we call DDH, developmental dysplasia of the hips. So be familiar with these terminologies. If we go to the other side, we look at the head, the eyes. Take note, red reflex in the eye is a signal for cataract. A yellow sclerae, or the white portion of the eye is yellowish. That's a sign of, or jaundice, that's a sign of liver issue. If you look at the abdomen, if there is vomiting that is bile stain, that means we have some gallbladder issues. You look at the limbs, we see terms like polydactyl. Poly means extra or many. We also have syndactyl. Syn means together. These are your fused digits. We take note of the lines in the palm. A single palmar crease is actually a sign of Down syndrome. Okay? So we have these as key guidelines when we do our head-to-toe assessment of our newborn. So that assessment is what we call APGAR scoring. APGAR stands for A, appearance, P, pulse, G, grimace, A, activity, and R, respiration. This is like our rapid assessment when the newborn is brought out into the outside world. So right away, we look at the general appearance and we score from 0 to 2. A 2 means pink. That means perfused body. A score of 1, there are signs of bluish discoloration in the extremities. That means not enough oxygenation. And a score of 0, the newborn is pale or blue. That is a sign of poor oxygenation. So whenever the score is 0, that is a bad sign. A score of 2 is a very good sign. A score of 1 is midway. So just like pulse, if the count is more than 100 beats, that's a 2 point. A less than 100 is 1, and no pulse at all is 0. G will be for grimace. No response is bad, so that's a 0. A good cry and even tries to pull away is very good, so that's a 2, while a weak cry is 1. As for activity, no movement is 0, active movement is 2, some slight movement, that is a 1. And for breathing or respiration, of course, no breathing is 0. A strong cry, that means the baby is breathing, that's a 2. If it's a slow, irregular 1, that is a 1. And so a very good point would be 7 to 10 points. This is good and in the best possible health. A bad score will be 0 to 3. That means the baby is in serious danger and need immediate resuscitation. A score of 4 to 6 in between means baby's condition is guarded, may need more extensive clearing of the airway, and so we need to suction the baby and check maybe there is something there blocking the breathing, and provide supplemental oxygenation. So again, this is your APGAR scoring. We also check the vital signs of the newborn. So the respiration, the count, normal count is between 40 to 60 breaths per minute. The heart rate is faster compared to adults, 120 to 140 beats per minute. And the temperature of the newborn is from 36.5 to 37.5. That means newborn is fine. She's not febrile. Now let's look at a detailed physical examination. As I said, our assessment will start with physical and then it will progress later to neurological. So we're just focusing now, part 1, on physical exam. So again, very first thing to observe is height and weight. So when we say length or height, we measure now the newborn from crown, which is the head, to heel, okay, the foot. The infant is flat supine, upside down, with knees slightly pressed down. So because the newborn tends to flex the knees. So the knees is slightly pressed down so we can get the maximum leg extension. We also measure the head circumference. You see it here on the slide, how it is measured. It is drawn across the center of the forehead in the most prominent portion of the posterior part of the head. So we have to locate which one is really protruding in the back portion of the head. That's where our tape measure should land. We also measure chest circumference, which is measured at the level of the nipples, which is about 2 centimeter less than the head circumference. So as you can see, the head is actually expected to be larger in terms of circumference, and the chest is only 2 centimeter less, so almost equal. Okay. Now, the average birth weight of a newborn is from 2.5 to 3.5 kilogram. If you observe in the picture, the newborn is measured nude, no clothing, because we want the real birth weight without extra thick jacket on. Then we observe, which is part of the APGAR scoring, the posture and the movements, but this time we are more detailed. So we put the newborn on supine position. On supine, it is expected that the arms are partially flexed, the legs and hands commonly turned a little to one side. You will see later that's what we call the tonic neck reflex and the more tonic neck reflex, yes. Hips and joints are partially abducted, and the movement is most evident in the face and limbs. So any unusual movement or lack of movement or imbalance, they're not balanced when they're moving. One side is the only part active and the other is not. This is something to be reported. We observe the color. We have cyanosis that can be physiologically normal. Cyanosis means being pale or there's bluish discoloration. So we have this peripheral cyanosis. So what do you mean by that? The baby is kind of bluish in the tip of the fingernails or the hands and in the foot. Now, this appear due to immature peripheral circulation. Now, remember the baby just started breathing, so the body is prioritizing the central organs, the head, the chest, okay, the central part of the body. So the peripheries are usually not right away provided with good circulation, and so it can appear cyanotic. So this is normal. However, if the cyanosis is central, meaning the chest, the face, it's pale, this is actually a bad sign because these are the areas that are supposed to receive first the oxygen, and being cyanotic, that means it's not receiving enough. So this can be a result of temporary respiratory obstruction or a more serious condition. Now, looking at the skin of the newborn, we can see, some newborn would have this vernix caseosa, which is a white cream cheese-like substance. And actually, those are normal substance because these serve as a lubricant when the fetus was sliding out from the vaginal canal. This is secreted by the fetal sebaceous gland, and this is part of a normal part of newborn, which will disappear within a few days. Then our newborn can also have this fine downy hair that can cover the newborn's shoulder, back, and upper arms. Some are also found in the forehead and the ears. We call this lanugo. And the younger the newborn is, the more lanugo. But the older the newborn is, the newborn now transition to become the 1 month old baby, there's less and less lanugo. Then we have this skin desquamation or peeling of the skin, which takes place a few days after birth, and they're mostly noted in the hands and the feet. So this is part of the shedding off of the skin. This is normal part of growing up of the newborn. Here you see these white spots in a newborn's face. These are actually what we call milia. These are newborn sebaceous glands that are still immature. Therefore, they appear as pinpoint white papule, and they can be found on the cheek, on the bridge of the nose. But after a month, usually this already disappears because the skin now learn to adjust with the environment. Then we look at the head and check if there are forceps mark. Okay. So this would happen to babies who are born with under a difficult labor, that vacuum forceps may have been used to help the baby come out. So when a baby is delivered via vacuum, or forceps vacuum, we pay attention and look at the head features and see if there are any trauma. Okay? There may be circular or linear contusions matching the rim of the blade of the forceps in the infant's cheek. If it's your regular trauma on the skin, the mark will simply disappear in 1 to 2 days along with the edema that accompanies it. So nothing to worry when it's just superficial. We look at the skin trigger. If a fold of a skin is grasped between thumb and finger, okay, it should feel elastic, and when released, it should fall back to form a smooth surface. Because if a newborn is severely dehydrated, the skin will not look smooth, but there will be a lot of ridges in it. Here is a buttocks of an infant with a bluish discoloration. We call that the Mongolian spots. These are slate gray to blue-black lesions, usually over the lumbosacral area. This is a sign of accumulation of melanocytes, and it takes about 7 years before it disappears. So we hear jokes in the past. I do not know if you remember yours, that elderlies may call out a baby or a young child and say, "Do you still have those blue spots? Because if you have, you still are a baby." Because generally these blue spots will start fade by the age of 7 years. Then we assess the head of the newborn. Okay. Now, a newborn's head appears disproportionately large. So that is normal if it seemed to be uh, larger than the chest, because the head is actually 1/4 of the total length of the newborn. And in that head, expect for fontanelles. Fontanelles are soft spot. Okay? The larger spot is in the anterior or the front, And then we have the posterior one, which is small, and it cannot be palpated readily because it's in like the ridge in the back upper portion of the neck. So here is a better picture where those fontanelles can be found. Okay, it's actually between those. You see this triangle, triangle in the frontal portion. That's a spot for a fontanelle, and in the back you have here a spot in between the crack in the back. That is between the two sagittal line, that a fontanelle can also be found there. Now, by the way, what you're looking as lines in the head, these are what we call sutures. Okay? Sutures, this is where bones in the head fused. And we have several suture lines in the head to connect different bones in the scalp. Okay, so we have the coronal suture, we have the sagittal suture, we also have the co- um, coronal, okay, coronal, sagittal, and the one coronal divides the head front and back, and then your sagittal right and left. So again, those sutures line should never appear widely separated in newborns, because later on those suture lines will be almost non-distinct, because the bones that are next to it would start fusing. Now, a separation of those suture line means the pressure inside the skull is increased, probably due to some abnormalities such as accumulation of cerebrospinal fluid. We call that hydrocephalus. So that suture lines will start to extend and the head goes bigger. On the other hand, when suture lines are also fused already upon birth, this is abnormal, because that means there's no room for the brain to expand and develop. Now, earlier I mentioned caput succedanum. Okay, so upon delivery of the head of the fetus, sometimes it can be traumatic when forceps are used, or the handling of the head. So it can cause some trauma, and that would be a discoloration, signs that there is some bleeding under. Now you have to differentiate that from a caput succedanum. Now, a caput succedanum is the swelling or the edema of the presenting part of the scalp. Okay, so when the mom is pushing the fetus head first, the presenting part, which is pushing on the perineum, can actually undergo some swelling. That swelling, you call that caput succedanum. That is normal. What is not good is a cephal hematoma. That means there is a bad trauma in the head and there's some bleeding. And the difference with the caput can look reddish, but it's it's superficial. While the cephal hematoma, there is a bleeding under or in between those bones. And so one signal would be uh, the bleeding or the redness does not cross the suture line. What's that suture line? That's the crack between the two bones. So it doesn't cross the suture line because the bleeding is underneath. So unlike your caput wherein the trauma is superficial, that's why it can cross the suture line, because it's just in the surface. We look at the mouth of the newborn and we check if there are any abnormalities such as cleft lip, cleft palate, or tongue tie. Okay? Tongue tie means the tongue cannot extend much because there is something like a extra skin attached to the palate. So palate of the newborn should be intact. Now, occasionally, there are one or two small, round, glistening, well-circumscribed cysts that are present in the palate. Okay? These are normal. We call that the Epstein pearls, which is a result of an extra load of calcium while the newborn was still in the womb of the mom. Now the chest looks small because the head is larger in proportion. Okay. Now some newborn can have breast engorgement and like milk is coming out. We call this the witch milk. That's the secretion of thin watery fluid, and the chest should not be retracted. When we say retracted, there is an indentation in the midline. That is actually not good. And also you can see the rib cage, and that means the infant is struggling with his breathing. So retractions are not a good sign. We look at the tip of the recently cut umbilical cord. We have to see two arteries and one vein. Okay, that is normal. That is what it should be. That means baby has been well nourished while inside the womb. And the birth cord should appear bluish white and moist because it was just recently clamped and separated from the placenta. And then later on, within 6 to 10 days, we would expect it to start drying up, becoming brown, and then later on will shed off. We look at the back of the newborn. Now, the spine of a newborn will typically appear flat in the lumbar and sacral area. Um, But you see here in the picture of a newborn, there is something in the back, like a hair is sticking out. So the base of the spine should be free of any openings, dimplings, because when there is a dimpling, that means there's a missing bone. There's so much hair growing, which is a sign that there is a defect in there, which we usually call a spina bifida or spina bifida occulta. Okay, so those are signs: the hair, the redness, hemangioma, that's the redness, the dimpling of the skin. Those are actually not good signs. We look at the anus and the genital area or anogenital area. So, anus of the newborn should be inspected to see that it is open. Okay, it is not covered by a membrane because when it's covered, we call that imperforate. That means there's no opening. So we will have an issue now with the GI of the newborn. We look at the male genital. We feel for the testicles inside the scrotum. And if one of the testicle is not there, that means it did not descend. We call that cryptorchidism. And so this newborn is subject for further evaluation. Now, the female genitalia, there are two flaps that we can observe. The labia majora that covers the labia minora. Now, some newborns could have mucous vaginal secretion. We call this a pseudomenstruation. This is normal. It simply means that the infant's system has cleared the hormones. And we look at the extremities. We look at the fingers and the toes and count. Okay. Syndactyl means it's fused. Polydactyl, there is excess or extra. Normal count is 5. We look at the crease of the palm. Okay, if there is unusual curvature of the little finger and a simian crease, which is single palmar crease, these are signs of Down syndrome. And of course, we wait for the first stool and the first urine of the newborn. Now, the first fecal material of the newborn, we call this the meconium. This is sticky, odorless, greenish black to greenish brown, and we should expect that the newborn should pass this within the first day or the 8 to 24 hours after birth. Otherwise, we will be in panic because that means the GI system is not patent from mouth to anus. So this is very critical and important. Now the urine is expected already as after birth in the 2 to 3 hours, okay, because the kidneys are already functioning even while inside the utero. So the first urine is diluted because the kidneys are still immature, and so the kidney is still trying, starting its ability to make concentrate urine. All right, so that's it for part 1. Let's pause here and we'll continue our lecture in the neurologic aspect of the newborn assessment.